Hello everyone, welcome. It's a fantastic 8:30 crowd. I'm Patrick Maher. I think it's about time we should get started. Welcome to Spin Doctors, TEG, and ROTEM in the emergency department. I'm Patrick Maher. I should mention I'm actually an assistant professor over at Mount Sinai in New York. I work in emergency and critical care medicine, and next year actually moving a little bit more towards the critical care end of things. Do have a couple of disclosures. So I am supported by currently a grant from the NIH. It's a T32 grant expiring off in June. I am not supported in any way by the Spin Doctors, although they did give me their name for this talk. So no disclosures with them. The goals that I wanted to talk about today was to, number one, to review the basic mechanisms of TEG and of ROTEM in the emergency department. I wanted to summarize some of the more recent literature which is coming out about these technologies and the ways that they're benefits. And I also wanted to go over just a couple of cases to highlight the ways that you might use them in your clinical practice. But I think it's first worthwhile reviewing that there's been a shift in the way that we talk about the treatment of bleeding patients, going back all the way to when we used to replete primarily volume with things like isotonic crystalloid using normal saline, eventually recognizing that these patients require a blood product transfusion, and after the publication of trials like PROMPT and of PROPER, recognizing that you should prepare these patients with a 1:1:1 balanced resuscitation ratio in order to support clot formation. In the future, this may even move towards things like whole blood for these trauma patients. And the reason why that's important is because of the recognition, at least partially, of what we call acute traumatic coagulopathy. And an acute traumatic coagulopathy is an acquired coagulation defect after trauma, which is more highly associated with an injury severity score on the upper end, but which is also associated with a substantially increased risk of mortality for these patients. One of the modalities that you can use to test for, to diagnose, and to treat these patients in your resuscitation bays is thromboelastometry. And thromboelastometry itself is a very old technology. Actually, it predates the PTT. It's from the 1940s, but really only with the newer devices that have been coming out over the past couple of decades has this become more commonly used, although it's still really rolling out. There's a lot of potential advantages to the use of thromboelastometry, notably that it's a much faster test in comparison to the conventional clotting assays, to the PT, to the PTT, to the platelet counts. It's a bedside test, and this means that you are running it yourself and that you're acquiring results from thromboelastometry as the test is performed, that you can use them to resuscitate. It is really the only kind of test that you're going to have available to you to demonstrate hyperfibrinolysis in these patients, which is a very important finding to know about. And then lastly, thromboelastometry is performed with whole blood. So unlike the kind of plasma-based clotting tests, which is the PT and the PTT, those are just kind of markers of your ability to form clots. This is the truth. This is your whole blood, uncentrifuged, being put into a tube and actually allowing itself to form a clot and measuring that process. But with a relatively new technology, and particularly with two flavors of this technology, with respectively thromboelastography, which is there on the right side, thromboelastometry, there on the left side. There's some confusion about it, and that's what I wanted to focus on at least to start. The underlying principle for both of these techniques is that when you put blood into a cup and you add a clotting factor to it, it's usually kaolin or tissue factor, you'll form a clot. If you allow that cup to spin with a pin which does not move, you'll be able to measure the force exerted by the clot as it forms over time on the pin as a torsional stress. And if you plot that torsional stress over time, that's how you come up with the graphs that the machines form. The other differences between the two techniques, and so really TEG over on this right side, sorry, on the left side of my chart here, the cup is spinning, whereas in ROTEM, the pin is spinning. You get a very similar graph in both of these. There are other differences between the two techniques. Previously, the TEG machines were limited to 2 channels, and so really only 2 kinds of tests that you could run at the same time. ROTEM had 4. The newer devices now that are made by these manufacturers, both of them are very easy to use. They use standard sodium citrate tube, which is like the blue top tube for coags, and actually they've become a lot more user-friendly, and both of them now have 4 channels. The graphs which are generated from TEG and from ROTEM look very similar as a result. So you get these graphs which are plotted over time as an x-axis, and they have an amplitude on the y-axis. You form a clot, and then you get this very large amplitude clot, which you measure over time. Unfortunately, The terminology which both of these manufacturers have chosen to describe the curves that are generated differs, but you could, if you chose to do so, make some comparisons between the two technologies, understanding that there's going to be numerical differences for the standard values that you should be using from the manufacturers. When you run a TEM, in this case, you get a graph that looks like this, starting off with a very small amplitude clot over time, and this is the green segment, and then eventually generating a purple segment, which is the initial formation of a stronger clot, going towards a very thick clot where you measure the maximal amplitude of it formed, and then if there's any plasmin in your sample, you're going to at least have some shrinking of the clot, usually after about 30 minutes is when this is measured, the measurement of fibrinolysis. When you divide this kind of graph into 4 different segments, you get the first segment, which is the initiation. This is dependent entirely upon coagulation factors in your bloodstream. This is the same kind of a thing which you're getting when you measure a PT and a PTT. The next phase, though, is the clot kinetics. This is when platelets and fibrinogen start to have an effect on the clot's strength. This is also when factor 13 builds a stronger clot, and you start to get an increase in the size of your graph. And then you start to form a stronger clot, usually at around 30 minutes, like I said, where you get this maximal amplitude that you can measure. There are various amplitudes that you can measure before that time. Usually 10 minutes is pretty predictive of the maximal amplitude that you will eventually end up with. And then lastly, though, the fibrinolytic part, where it shrinks down and becomes a little bit smaller. For TEM, a standard 4-channel test will involve usually these 4 different results, each of which uses different kinds of agents which you add to the mix to get a different kind of part of the coagulation cascade. And the 4 parts that you're going to end up with are the XTEM result, which is the measurement of the extrinsic pathway, the INTEM result, a measurement of the intrinsic pathway of clotting, the FibTEM result, which gives you some answers about the fibrinogen contribution towards clot formation, and then the APTEM, which is actually with the addition of what's called aprotenin. Aprotenin is an anti-fibrinolytic agent. It's very similar to TXA in a lot of cases. This is what you'd add if you wanted to have an assessment of early fibrinolysis or to get a sense of what your patients might do if you added TXA to them. There are analogies, then, for each one of these curves to what we're used to seeing as conventional clotting tests. And if you wanted to think about measurements of extrinsic pathway, you're thinking about the PT. If we want to think about intrinsic pathway, more similar to a PTT, the FibTEM is closely analogous to the results that you will obtain from a fibrinogen count. And for the APTEM, there's really not a close correlate to that. There's really not a conventional clotting assay which you could compare it to. This is that same 4 set again. I would say that for TEG, although I've chosen to focus just for sake of simplicity on ROTEM throughout this talk, you do get very similar results from the current technology that's tested. Basically, if you wanted to compare like a rapid TEG to an XTEM, that's a very similar graph. A kaolin TEG, which is a standard TEG, to the INTEM. There's a functional fibrinogen assay which you obtain from a TEG, which is very similar to the FibTEM results that you get here. And then actually for the current generation of TEG testing technology, the 4th channel that you obtain, it's not similar to an APTEM. It's actually ADP platelet testing, which gives you a different kind of study result. So, just going back to then some of the conventional clotting assays, for all of these usual tests that we're used to seeing, you could, if you chose to do so, pick out a number from a ROTEM result which would correlate very highly with it. The correlations are never perfect, and that's really just by design. This test was never designed to predict the results of a PT or a PTT. It was designed to replace the PT and the PTT because those are markers of potential clotting, whereas this is a whole blood assay of holistic clotting assessment that shouldn't be necessarily perfectly correlated at all. But because these do correlate, it means that you can use a ROTEM to diagnose some things which are conventionally diagnosed using a gold standard of conventional clotting assays. And the example here that I've used is trauma-induced coagulation. Trauma-induced coagulopathy is diagnosed using a gold standard of INR, an INR of greater than 1.5 in particular. And the XTEM, which is most closely similar to the PTT, has a good sensitivity and a good specificity for that. But the advantage of using a ROTEM for the diagnosis of acute traumatic coagulopathy is the time. Because for this particular center, which chose to compare its normal lab return to a bedside ROTEM test, they were finding that they were getting a turnaround time of their standard labs of about a half hour to an hour, which is pretty similar to what I think we're seeing in our center. They didn't measure fibrinogen testing, but in my experience, fibrinogen would, if anything, be a little bit slower than some of these results. But they were able to get XTEM results in less than 20 minutes. And using the case study of the amplitude at 10 minutes, which you see here from the XTEM, that's highly predictive of your maximal amplitude, which you will eventually obtain. And that was being obtained in less than 14 minutes for this center. So about half or a quarter of the time as compared to the standard coagulation tests. But maybe this is best illustrated in a couple of cases for the other kinds of benefits that you might see with TEM in clinical practice. So this case is for a multiply injured patient after trauma. He was being ground transported to your center, which is a trauma center from a smaller hospital. This hospital didn't have a TXA protocol, so he didn't obtain that, but they were able to give him some blood, and he continues to be in shock, continues to be transfused. I would say that your center, which is capable of running a ROTEM, is doing so, and it obtains this result. And what you recognize here is that this patient has formed a large, strong clot, which is great, but unfortunately this patient has then shown a catastrophic collapse of the strength of their clot, in this case about after 20 minutes. And you recognize that this is a patient who's developing what we call hyperfibrinolysis following trauma. This is a very important finding since hyperfibrinolysis over about 3% at 30 minutes is associated with, number one, a substantial increase in the requirements for blood transfusions measured with an MTP. And using that same cutoff of 3% at 30 minutes, you also see a pretty substantial increase in mortality for these patients, which only gets worse the more hyperfibrinolysis that you develop. The obvious question becomes for this patient, how should you treat them, and would you be able, using this ROTEM result, to justify the administration of TXA, even though they're outside of what you'd consider the usual window based upon the crash studies? Unfortunately, the answer to this is really not clear. The current data would see that for patients seen in a U.S. trauma center, and this center actually did have a TEG-based strategy for the administration of TXA, none of their patients seemed strongly to benefit from TXA, and in the patients who you would think would benefit the most from the administration of the antifibrinolytic drug, those patients who had hyperfibrinolysis, they showed a higher mortality for those patients who they administered TXA to. But what about in the opposite setting? This is the setting in which you have a TEM result or a TEG result which shows a decreased fibrinolysis after trauma. Anything less than about 0.9% is considered low on this result, and you may be thinking to yourself that this is excellent news, that your patient has formed a very strong clot and that this clot doesn't seem to be going anywhere. But, unfortunately, what you're recognizing in this patient is the phenotype after trauma of a fibrinolytic shutdown. Fibrinolytic shutdown is not the standard physiologic kind of fibrinolysis that you see in all of our patients who are walking around with standard values. This is a pathologic state, which is fairly common with incidents after a severe amount of trauma. And it's associated with an intermediate mortality in comparison to physiologic, which is relatively low, but it doesn't approach the mortality which is seen in these patients with hyperfibrinolysis after trauma. What do you do about that? How would you treat it? I would say that for now what we can say is that TXA does not seem to be the answer, but really nobody knows the answer to this question. It's something that still bears out more study. There are hypotheses which are being generated. This was taken from a subset study of the proper data, and the current thinking is that rather than being an opposite response, an opposite phenotype from the hyperfibrinolysis patients, these patients who are having fibrinolytic shutdown really just might be an intermediate step along the way towards getting that hyperfibrinolysis. And so going from this left side of the chart with normal findings, you're eating up your coagulation factors, you're eating up your fibrinogen, and then eventually you'll have fibrinolytic shutdown prior to rebounding your fibrinolysis and developing that worse off state. My next patient is a 20-year-old patient. She's had a normal spontaneous vaginal delivery, but unfortunately she begins to pass large clots and your patient is developing postpartum hemorrhage. And for your patient, you've chosen to use a TEM-based resuscitation strategy. You obtain this result, Without going through the actual numbers here, I can tell you that both the XTEM and INTEM tracings are relatively narrow amplitudes, that this patient is coagulopathic, and in particular that the FibTEM tracing here is extremely narrow, and so you believe that your patient is coagulopathic because of a low fibrinogen amount. And this is a really important finding to diagnose, because what you want to know is whether you need to call up your blood bank, tell them to start thawing out some cryoprecipitate, which is going to take some time, or whether you want to start breaking off bottles of a very expensive fibrinogen concentrate that you can give. But I think that knowing this information, what you maybe see if you resuscitated this patient is that their early postpartum hemorrhage results would show a normal TEM, normal numerical values that you obtain from that for the clotting time and for the clot firmness. When you obtain the fibrinogen concentration, which may be delayed, it probably is normal. For patients with late postpartum hemorrhage who've gotten rid of all their fibrinogen, they've used it all up, that's when this TEM result becomes shrunk. Their clotting time is prolonged, their clot firmness goes down, they have a fibrinogen level which is low, but restoring the fibrinogen amount to the patient fixes all of these problems and fixes the patient. And there is evidence, actually, of at least one center who went towards a ROTEM-based resuscitation strategy for their patients with postpartum hemorrhage. And they showed really good results. They were able to substantially decrease the cost of hospitalizations for the patients, nearly half it. And this was powered because they were having fewer transfusions, they were giving different products and the right products, and their patients had fewer transfusion complications and shorter lengths of stay. There are also resuscitation strategies using TEG, in particular in the United States, at least for trauma. The values that are used as triggers and the kinds of cutoffs for these resuscitation strategies are center-specific, and they're based upon their own values, which they've decided should be used for transfusion of patients. And likewise, that corresponds to the different kinds of products which you think should be used in all these cases. So there's no universally agreed upon strategy, but this has been studied in trauma in the United States. And just to kind of hammer this one last point home with the fibrinogen, since I think this is an important role for the TEM technology, these are two different sets of 4-channel studies for ROTEM, the patient on the left and the patient on the right. This I wanted to use to illustrate the difference in patients who require platelets based upon the ROTEM results versus the patients who require fibrinogen based upon ROTEM results. I'm going to highlight just the FibTEM aspect of their studies to show you that the patient here on the left has a very narrow FibTEM curve, whereas the patient on the right has a fairly normal-looking FibTEM curve. This would indicate that although both of these patients were coagulopathic, the patient on the left was coagulopathic because of a low fibrinogen. The patient on the right is coagulopathic probably because of some other mechanism, probably involving platelets, and so you're going to give them different products. Okay. But despite all these benefits, I think there are substantial limitations that should be addressed. Number one, ROTEM and TEG are not sensitive towards all problems with bleeding. In particular, they're not sensitive to aspirin and Plavix and other kinds of antiplatelet agents. You can add on technology to both of these machines now, which will do multi-plate assessments of qualitative platelet function and will address some of these deficiencies, but it's not standard from the manufacturer. It also doesn't address any kind of coagulopathy caused by temperature, since the blood gets warmed up to 37 degrees when you run it in the machine. There are some mixed study results, in particular with regards to the benefit of using these strategies for ROTEM and TEG-based resuscitation in trauma. Not all studies show reductions in transfusion. Not all studies show improvements in patient outcomes. There's a substantial lack of training with these devices, I think, also. If you're graduating from a U.S. residency program right now, you've probably, I hope, heard at least of TEG and of ROTEM and of viscoelastic testing, but you're probably not considered an expert in it, and you're probably not as facile interpreting the results of the studies as you would be with conventional clotting tests, the things that you're used to seeing every day. And for that point also, there just are other lab options, and so I think that if your hospital is able to address, in particular, the time that it would take to get a PT and a platelet count and a fibrinogen count, which some hospitals can do, that does restrict some of the benefits that you would have seen if you moved to an entirely viscoelastic method of monitoring your patients. But I still think that this is probably something that you'll see not less, but in fact more of in the future. It definitely has benefits that you could point out to tailoring your resuscitation of patients at the bedside. It will see substantial benefits if you're used to seeing delayed conventional lab testing, and it is one of the only technologies which you're going to be able to use to diagnose fibrinolysis in a broad set of patients. Still, though, further studies are needed to clarify this role. And thank you. Yes. Oh, actually, sorry, we have a microphone in the middle.
So great talk, overall summation of thromboelastography. Two quick things. One is would you use this in the end-stage liver disease patient, which I think that it's really good, useful. And the other thing is that with the trauma patients, do you think with the no change in mortality is the activated protein C and where you are in your activated protein C and your fluidity of it? Because what we're seeing is that it's it's not binary. And so when we're taking our tag, it's not always where they are in their trauma injury and their hyperfibrinolytic state. Do you think that's affecting the mortality rate?
With regards to your first question, so liver disease is an interesting kind of coagulation state because the INR is always going to be elevated because of the lack of production of factors. The thinking is that you can use TEG to assess those patients a little bit better because you're also having deficiencies of your protein C and S of your antithrombin, so this may reflect more of a balanced coagulation state, is I think what you're getting at with that test. And so for those patients, if you were concerned particularly just about their bleeding risk, TEG and ROTEM might offer some benefits over just relying solely upon an INR. And in particular about those patients, if they're going to be listed for liver transplant, you may want to not give them some FFP because that's going to move them down on the transplant list. With regards to your other question about trauma, I had a hard time answering that one. So if I think I'm following you, your question is whether these patients are seeing alterations in the protein C and S function after trauma, which would affect their fibrinolysis results?
No, that you utilize that initial trauma, your activated protein C is high, then after 24 hours you complete your activated protein C, which is changing your coagulation state. And that when we're seeing these patients, we're utilizing our tag to direct the resuscitation, but we may be delayed in that aspect, and that may be why we're seeing a change in mortality rate, no change in mortality rate.
Yeah. I don't have a good answer to it, to be honest with you. Yeah, I think that the coagulopathy after trauma is still something which is undergoing investigation. I couldn't say myself, because I don't research that particular area, how much role protein C has in it versus just depletion of clotting factors. Actually, I could just take a question now then. Yeah. No? Okay. Okay. Great. Well, thank you then.